Okay, okay, let's start. I'd like to welcome everybody to the RAMP webinar for August. Radasa is really pleased that we've been able to offer webinars, monthly webinars from May through to November. If you want to know what the webinars are, they're available. The list's available on our social media sites on Facebook, Instagram, and on Twitter. But tonight we are welcoming Dr. Sibongile Mandondo, who has given many webinars for Radasa and Radasa members and for people who are working in rural hospitals. And she is part of the Amathole District Clinical Specialist team, and she's a specialist in obstetrics and gynecology. And she's really committed to her work. She's passionate about working at community levels and giving people support and clinical and clinical governance. And she travels extensively throughout Amathole, training doctors and nurses, assisting with ward rounds in district hospitals, and doing clinical sessions in East London Hospital as a consultant. So we're really happy to have you on board, and we are looking forward to the talk. For those of you who've not come to a RAMP session before, we do the presentation. You can put questions in the chat, but there is time at the end of the presentation for questions. Okay, Dr. Mandondo, do you want to start?
I want to say thank you. I want to say thank you. It's been a long day. Can you still hear me? Am I still audible? Yes, colleagues?
Yes, we can see you. Oh, just go back. Yeah, that's your heading slide.
All right, thank you.
Yeah.
All right, good afternoon, colleagues. As you have heard, I'm a district clinical specialist in Amathole, we're a rural district. I'm also a member of the NCCMD. So NCCMD means that it's the body National Committee for the Confidential Inquiry into Maternal Deaths. So before I present this, you must understand this properly. So what happens is that there's provincial assessors. So each province will have a set of doctors, a doctor and a midwife from each of the regions. And then when you've got that set, it forms up the provincial committee. Then from that provincial committee, one or two people will represent the province in this ministerial committee. It's a ministerial advisory committee, which is now meeting once a month. I mean, it means once a quarter. So what then happens is that every time there's a maternal death at any facility, the maternal death, I don't know if there's an alarm or it's my phone or what, but so every time there's a maternal death in each facility, it's mandatory that the maternal death is notified. Even if it's a coincidental, it's a swimming, it's a drowning, it's a stab, it's an MV8, it still gets notified. Then when it's from there, it will come to the province, and then the province will set up the meeting once a quarter of the maternal death assessors. So there you're supposed to assess the maternal death and find causes, avoidable causes, the profile of the patients and everything. And once you've then come together, as the team, you complete and you type, you enter your findings into a report, which is what is called this MAMAS report. So then after that, every year we deal in trinium. So every year there's a report. So the last report, if you Google the Saving Mothers report, the last report you will get is the one from 2023. Then in order to then you generate 2023, 24, then 25, 2025 becomes what you call a triennium. So then after that, you get a report now, which is for the summary of what happened in the 3 years. So if there's anything that's going wrong and that's alarming, that's changing, the minister is privy to these reports on a every 6 months, or if there's anything that is flagged by the committees. For example, I'll make an example when there was that Stevens-Johnson syndrome, and many people were dying of Stevens-Johnson, then there was a quick alert to the minister within 6 months to say, Shay, we're just worried about nevirapine, and with the nevirapine, then people said, look, there's just too much Stevens-Johnson syndrome when the patients are severely immunosuppressed. So because of that, that nevirapine was changed to tenofovir. Now it's changed to dolutegravir. So then that committee has a right to alert the minister of problems, and then when those problems come to his attention, then he can quickly then say, no, you can go ahead and you can change, and that will influence the guidelines. On the other aspect, is the committee can say, oh, this is emerging as a trend. Maybe we need to improve our training on a particular condition. So once that has been identified as an issue, then the training is actually improved, the training platform. So what I'm saying is that as the representatives now in each province, you get given a topic. So my topic was medical and surgical disorders. And then in addition, you also get sent files. This is now files from different provinces. So of patients with medical and surgical disorders, so that you can just verify those findings and then maybe come up with an assessment, an analysis, or a recommendation, or what we're going to call these recommendations. So for the initial presentation, I'm just going to focus now on what were the findings of these medical and surgical disorders, and now with a focus on peripartum cardiomyopathy. But because you're not here to just listen to statistics, I've put some slides on the theory now, the content of the theory around the diagnosis of peripartum cardiomyopathy, what causes it, what is the natural history and the progression, and I will add this to this presentation. I hope that summarizes how the presentations come into being, and it actually just summarizes how these findings were arrived at. So just to start, I did not give you a presentation outline. So if you look, so we have got findings from the triennium, and okay, so if you look right in this triennium, right, medical and surgical disorders used to be number 4 as a cause of medical or of maternal deaths, right? So if you can look at the triennium now, which was 2020 to 2022, there was 513 medical deaths that happened because of medical and surgical disorders. The institutional maternal mortality rate has remained constant over the last 3 triennium. So which means we haven't moved, Medical and surgical disorders were the 4th most common cause of maternal deaths. And of this, like 89%, 89 happened in the district levels or lower, and previously it was 87. So the question is, if the patients are dying at the district, were they not accepted? Did people not recognize the problem? Why did they die there? So that we can identify factors that we can actually look at, especially in the district level on the CHCs, that could have influenced this. So this is a graph that is actually showing you the institutional maternal mortality rate. If you start from 2017, so you can see it remains at 16.4 maternal deaths per 100,000. We don't say percentage, we say 16. So IMR is 16 per 100,000. And you can see there was a slight drop in 2019, but you can see 2022, there was a little bit of a drop, but generally it has remained constant. So if you looked at the triennium in question, what was the leading cause? So the leading cause of death in that triennium had been HIV, but remember there was also COVID. So it was 29. So COVID was also treated as a non-pregnancy related infection, and it accounted for 29% of the deaths. And then following that, you can see that the second cause was then obstetric hemorrhage, and then the third cause was hypertensive disorders, and number 4, as we've said, was the 513 cases which had died of medical and surgical disorders. When you look at, sorry, I just need to, okay, so that is again this reflects. Now, then the triennium ended, and then we started 2023, but look at what happens, which was a big concern. If you look at 2023 maternal deaths, medical, surgical, and HIV, remember I told you HIV had contributed, if I look at the previous slide, 29% to the deaths. Now look at what happens in 2023, a complete shift. The HIV care improved well and did well, and you'd find that for HIV, it was accounting for 17.4% of the maternal deaths, which is 164, but the medical and surgical conditions are now rising, accounting for 16.9%, which is a mortality of 17.2. So now this means that we are not improving in terms of the recognition and the management. And soon as we can see that these medical and surgical disorders will actually overtake HIV if we are not careful. And then you can see obstetric hemorrhage was sitting at 16.5, and then the hypertension at 16.9. This is nationally 2023. So this is the last published report. So now if you look at the 2013, the 2020, the triennium, what was causing these medical and surgical conditions? Of course, we can't predict what conditions the patients have underlying. This is now underlying conditions that people have, which are not their pregnancy. And then that were the cause of the complication without anything going wrong with the pregnancy. So the first and the biggest category you can see was the cardiac disease, which is out of 513, 150, it makes up a significant percentage. And now a person, I would have expected that the cardiac disease is the patients who have got underlying, who have got valvular disease or valve replacement and all that, but no. Of this 157, you can see that 101, which is actually 64%, had cardiomyopathy. And then everyone else, the other cardiac, rheumatic heart disease, other heart conditions, were secondary to that cardiomyopathy. And the question is now, what is this cardiomyopathy? Then there was respiratory disease, pneumonia, and other causes. Then there were patients who fell pregnant with cancer. And you can see that this was a problem. Neoplasm was high in Mpumalanga, Gauteng, and the others. Then other people had CNS disorders. Others had GIT disease, be it autoimmune disease and all that. And then the last one we've remarked about is suicide. So if we're looking in the Eastern Cape, or if you look at Eastern Cape, the mortality related to suicide actually doubled. So with Eastern Cape and Mpumalanga, and the question that raises is that why do people have to end up committing suicide? Will they commit suicide because they had received for a TOP and the TOP was not available to them? Or are the TOP services we're not promoting TOPs, right? What about the mental health screening? So the changes that you pick up in these will influence the changes that you'll see in a maternity case record, things get added, or eventually even in the training. And as most of you could say that if you look at the perinatal the maternity care guidelines, which is called the perinatal guidelines of 2024, you can see there's a significant investment, which is of 3 chapters on the medical and surgical, on the intimate partner violence, on mental health in pregnancy, respectful maternity care, because these are all the things that this is an effort to recognize patients who have a suicide risk. So because we are on Zoom, I would ask you what would happen if you were confronted with a patient who said, I want a TOP this week. We're confronted in one of my hospitals with a patient who had said they wanted TOP. And the hospital said, you are 23 weeks, you are not eligible for a TOP according to the guidelines of South Africa, the CTOP guidelines of 1996. So the patient said, no, she was referred to the social worker and she said, I do not want this pregnancy. She was given all the options on adoption and everything. But she said, no ways. I am not carrying this pregnancy to term. And she was just adamant to say, then she was admitted overnight, hoping to calm me. And the question, she said she did not want this pregnancy disclosed to anybody, not even to her mother or her parents. And when she couldn't be helped with the TOP, she said, please get me out of your hospital. I'm going to commit suicide. I'm going to throw myself in a river. The first thing I lay my hands on, I'm going to poison myself. I'm going to kill myself. I want you to know that I am going out of this hospital to kill myself. The question is, as a doctor, do you have an obligation? So when there is somebody who's saying, I'm going to kill myself, they are threatening suicide. They're not threatening, they may do it. What rights do you have? Can you then divulge the diagnosis to the parents, disclose without her consent? Can you send her off? So these are the ethical dilemmas that this whole issue of medical and surgical disorders exposes us to, and of which we decided that we could not. The patient was not in a mental capacity to go, and number 2 was very adamant about the fact that she is going out and she's going to kill herself. So we had to today consult, send it to the social worker again, and we had to then agree with her that we have an obligation to disclose to your family or to somebody about your intention. so that if you proceed with this intention, we as clinicians can have clearly disclosed. So I don't know if someone will disagree with me. So my question is, if these patients die, where do they die? So if you're looking at the patients with medical and surgical disorders, you can see that the yellow graph is there, is there right at the top. They are referred, you know. So you can see the majority of these cardiomyopathic deaths, they die even though they have reached their tertiary hospitals. And you can see that in most cases, the yellow line is the tallest, which means that it's not like the district hospitals harbor these patients and keep them. They do, but some of them die even as they reach their tertiary hospital or their central hospitals. Now, if you're just looking at age-related risk, so we must also, with medical and surgical conditions, you can see that the maternal mortality with age really increases, and the highest peak will be seen in the 40 to the 44-year-old, and then followed by the 34, which was at 34 per 100,000. And it is actually clear, colleagues, that if we do not offer contraception to the 40-year-olds and talk to patients about contraception and tell them that you have completed your family now, how about you starting to use contraception? Patients will fall pregnant again. And I can count the number of facilities that are still doing a BTL. So because we're not doing BTLs, we've opted to put an IUCD, intrauterine contraceptive device, in patients, and that is still at cesarean section. Now we're putting postpartum IUCD in patients within 48 hours because we're trying to curb this. So when our services decline, our BTLs decline, this happens. What happens to maternal mortality? It rises. So as a clinician, you should be on a very serious watch when you're dealing with patients over 35 years of age and those that are over 40, because they have a mixture of comorbid conditions, be it related to their obesity, to their chronic medical conditions, and the pregnancy becomes a secondary strain on these patients. And then, if you look at the causes, especially in this category, cardiac disease was high and neoplasm. So, but then how does neoplasm work? Neoplasm can be found because patients will fail to gain weight and they become anemic. So these are subtle signs that most people will miss, and therefore the cancer will not be found. So whether the cancer is in the blood, in the ovary, or wherever, but we must really say, if patients are not gaining weight or losing weight within pregnancy, we must suspect neoplasm. And then the cardiac disease, we know that advancing maternal age is a risk factor for patients to have cardiomyopathy. And also, some of them have other hypertensive heart disease, which further may cause their hearts to be bigger and all that. And then, if you also look at the 15 to the 19-year-olds, what is the leading cause of these patients? Definitely, we think we would have thought that it's also going to be hypertension. But remember now, this is in the patients with medical and surgical disorders. So, yes, the maternal deaths are highest due to preeclampsia if you were looking at generally. But if you're looking at the patients with medical and surgical disorders, the reason the young people between 15 and 19 die, it is because they are committing suicide. And therefore the mental health, and we need to link them to the perinatal mental health programs. And we also need to, there's a suicide risk, 08 100 567 567. So that suicide risk, we need to link them, to counseling and supporting services, right? There's another number, 800 456 789. These are numbers that go and familiarize yourself with the management of patients who has a mental health disorder, be it the anxiety or depression related to pregnancy, so that we can actually try to improve access to services for the patients, the younger patients especially, they're at risk of suicide. If we look at now, why did they die? Medical avoidable. Yes, the patients can book late and book present late. But what about the medical colleagues who are doing trainings, ESMO, and the guidelines are there to curb these issues? So you can see that at the health centers, so this is the proportion of avoidable factors by level. CHCs, most of them have no doctors at night, no x-rays facilities. So you can see that the biggest problem is that the initial assessment is incomplete. So the persons, there may be no stethoscope, there may be no SETS monitors, and people may miss the diagnosis because the examination is incomplete and maybe they can't verify their findings. But even when they have picked up abnormal vitals, which is a lot of the time a pulse of more than 110, the diagnosis still remains mixed. What worries is the issue of the district hospitals, which are in orange. So the peak for all of these problems is in the district hospital. And so if you're looking at district hospital, you can see there could be a problem recognition. And then if the people don't recognize the problem, what will happen is that they will keep the patient until she's deteriorating and deteriorating, and they delay in referring the patient, or they continue to manage this patient at their level. And therefore, for those 86 patients that I talked about, they were managed at the wrong place. The patients had, if you look in retrospect, you can see that, look, this patient was sick, she had edema. These patients are not going to have ascites and pedal edema, raised JVPs. Sometimes they start with just anemia and a rising pulse. So then it means in the district hospitals, they continue to manage these patients who have cardiomyopathy and don't refer them, and manage them incorrectly, and the management is substandard. So, and the monitoring can be few. But what's the problems in the tertiary hospitals? So you can see problem recognition is not a big problem in the tertiary, but with the medical disorders, even in the tertiaries, because they are so focused, because they are in departments, everyone will just focus on the pregnancy outcomes, and they may miss the medical conditions. And why then are we training ESMO? So when we're training ESMO, we always say the big five, the forgotten four, and then the core one and two. So if you can see, tertiary hospital here will miss a problem, right? Even private hospitals missed the problem with medical and surgical, because people are so compartmentalized. They say, oh, I'm in maternity, and they go to the core. What's the pregnancy? What's the dating? Is the baby alive? Is the fetal distress? And they respond well to those things, but they miss all the signs. So that is why in ESMO we say, take a history, interpret your vitals, stabilize the patients, then you can go to the full examination. And the forgotten four, it also talks about HB, musculoskeletal system. You look if there's evidence of DVTs, and you have to look at your glucose in your patients and be sure what's your HIV, because it can change the differentials. So it's very, very important that we actually use the right approach to actually cap this. So what has been the recommendations? So really is to strengthen the SRH services and integrate contraceptive counseling. Then with teenagers, they need to have learner pregnancy, and they need to be allowed to come, so that you remember a teenager may have last seen a doctor when they were doing the immunizations. So if they have other cardiac or other conditions, these may be missed altogether, and the first time they see someone is when they are pregnant. So there is an app. If you can go to your phones, you'll see an app which is called the Be Wise app. So this app is to promote use of healthcare facilities by youth, and it talks to them about symptoms, signs, even some of there is even a place where they can take pictures of what they think is wrong. They can say, oh, my neck is swollen. They can take pictures and put it there and say, look, I have this problem. And they can be anonymous about the question, and then say, and someone will attend and respond to say, maybe you should do this. So it does look like the multidisciplinary clinics, because I think if you give a physician a pregnant patient, they'll miss things. But if you give a obstetrician a pregnant patient with medical problems. So if you look at the current maternity care guidelines, we need to start using these early warning charts. So the early warning charts, colleagues, are supposed to plot vitals in a certain pace. So please go back and look. So for every vital, if it's green, then it's amber, it means there's a problem, and then it becomes red. So for example, if you're talking about a blood pressure, once you find the systolic blood pressure is 90, it will then be in the red. So when you have two vital signs that are falling within the red, so that's already a near miss or a flag that like something's wrong with this patient. So it's not important in primary healthcare to know what is really the problem, but I think it's to recognize the problems in the early warning charts. And we've made clear recommendations that even during the antenatal period, antenatal admissions, there's two charts, antenatal admission and the postnatal admission. And in the antenatal admission, you need to make sure that if you do have a red a red, the guidance says, if you've got a red vital sign, then somebody else must double check the finding. So if I had an abnormal blood pressure, then recheck the blood pressure so that somebody else can also see. And when there's more than two, right, and then you manage the problem, if you can, then you must refer somebody, call a doctor, or let somebody know. When you've got two red vitals, it's a warning, maybe for a further referral for admission. And it is clear now that the basic ICU and cardiac modules need to be included in ESMO to deal with this level of the pathology of the disease that we're dealing with. The ONG registrars now are starting to do compulsory rotation in ICUs. And then it's also important for the screening of mental health and linkage. So if you have a child or a teenager that you think that requested TOP and it was not granted, or who is not very happy to be pregnant, many pregnancies are unintended, but somebody who is distressed then needs to be linked to a ward just so that they can follow them up. And I also think that we need to be upfront. Colleagues, we all walk around the streets and we see posters that say pain, cheap, safe, painless abortion. This is self-induced TOPs. And we might not have the services to do TOPs, but outside, as patients walk around, they do not know that is an illegal TOP service. So when they want termination, they are actually going to these providers who are giving them higher doses of misoprostol, which is causing them this misoprostol that they are taking is causing uterine rupture, because in those practitioners, they do not check the gestational age and they do not know if there's any limitation to the misoprostol you can give. So when you see the mental health issues, it's important that you tell people that, look, there is those pills out there. I even go to the extent to tell them that, look, if you want to do a TOP and you self-induced, if you do, those people will give you 3 tablets. They give them 600 micrograms. They say they must take all of them or put them vaginal. So I even tell the patient, you have to break it into quarters. You need at least maximum 50 milligrams. Or if you put it in there, you need to put it in water and take 25 mils at a time. So that at least even if she does that, she's taking reasonable doses to protect herself from a uterine rupture and further complications. Then the patients, the investigation of shortness of breath and tachycardia. I think in the maternity care guidelines, these have been dealt with, and with a very clear algorithms on how to manage shortness of breath and tachycardia in both settings. And then the other problem that we've seen is that we can refer patients to the tertiary and regional hospitals antenatally, but when they are discharged back, the discharge care summary is not provided for you to give clear guidance on what happened, what is the treatment, what is the plan, because sometimes then the physicians will say repeat echo in a month, or they will say we'll review this patient after this period. And then there is what we call a shared care for this patient. And you may not even aware that the patient had crashed or the patient was dialyzed and therefore has improved. And even the delivery plan may not be clear to you as the doctor who sent. So we really need to engage the tertiary hospitals to actually assist us with these high care discharge summaries so that we can actually make sure that patients who had near miss interventions can be delivered at the right place and that the follow up at least is at the district hospitals, not back at the clinics. The joint clinics are difficult, but they are doable. Now, in the district hospitals, there's no high care. So what is supposed to happen is that in every district hospital maternity, and especially in the labor ward, there should be a high care area, maybe just one bed, one room. And in that room, you need to make sure that you've got everything. You've got monitors, you've got SETS monitors, you've got ECGs, you know where the ECG is, and then there's the resuscitation box. All of those things need to be available. And you also need to make sure that yes, you've got the what is this, the resuscitation trolley. In that room, you've got oxygen. So it's in this very room where you should be able to have rebreather masks. We used to have exaro masks, where you should have ventilators if possible. And therefore, if there's any patient who's unstable, they should be in this room to get those 15-minute observations, then 30 minutes, then hourly. Or once the patient is waiting for the transfer to the next level, they're not just sitting in the bed where they were initially examined, so that you can make sure that these patients are monitored well whilst awaiting transfer to the regional hospitals. So now I am going to move to, I don't know if there's any questions, but maybe you'll allow me to, Steph, you can guide. I'm going to stop now specifically. This is general concepts about what we need to do to reduce these deaths. But I'm going to focus specifically now on pericardial cardiomyopathy. And I just as a disclaimer, part of this data that I've put here has been submitted to the SAJOG for publication. So allowing me to proceed, and then we'll take questions at the end.
Yes, that's
Steph?
fine.
All right, excellent. So colleagues, basically the objectives was really to do the sub-analysis to determine the causes of maternal death with an emphasis on cardiomyopathy to see how we can improve. So how did this happen? Basically, we've got this database called MAMA. So I was not able to view all the 100 files. I saw some, but it was like there's a system where it can collect all the information about medical and surgical disorders. So we didn't do record reviews, but I looked at an analysis of the system and then got further sub analysis until we found the problems. So just to say, you must understand what cardiomyopathy is before you understand. So I'll just teach you a little bit about it. So basically, the guidelines come from the Heart Failure Association of the European Society of Cardiology. Ne? So there was a working group from 2024. And then the discussion was really that, look, this is an idiopathic cardiomyopathy. This patient presents with heart failure, shortness of breath, edema, right, due to left ventricular from left ventricular dysfunction towards the end of pregnancy, right? And this happens in the month close to delivery. So not make a diagnosis of peripartum cardiomyopathy before the patient is 36 weeks. This is for the patient without any background history, but they must be 36 weeks and more for you to say you have a diagnosis of peripartum cardiomyopathy. And the left ventricle need not necessarily be dilated. But if you have done an echo, you can get an ejection fraction of 55 on the echo. But the thing is now, we don't have access to echo. So the diagnosis, you need not always have an echo, but it is part of the diagnostic criteria. So as I said that now, when does it end, the condition end? So the thing about peripartum cardiomyopathy is in the last month of pregnancy, but it ends at the end of the 5th month of pregnancy in the postpartum period, right? In a woman without pre-existing symptoms, no signs, no history of heart disease, and in the absence of any identifiable cause for this cardiac failure. When you can use as the stricter criteria, this is when you do an echo, and there you can look at the ejection fraction. So this is a separate stricter criteria. It's different. You can make a clinical diagnosis, a diagnosis of exclusion on clinical grounds, but you can use the left ventricular ejection fraction of less than 45. And when you do, that can be, and then you can have a left ventricular fractional suctioning or the left ventricular end diastolic diameters of less than 2.7. So the criteria may be different. So the risk factors, they vary. So this is, as I showed you, advanced maternal age, high parity, high gravidity, twin pregnancies. Africans, it's common. Patients with hypertension could have it. And then patients with underlying cardiomyopathy or previous cardiomyopathy in previous pregnancies. So if you look at the incidence, it affects in South Africa, you have got one, I mean, in other countries, it's 1 in every 100,000, in every 1,000. But in the US, you have 1 per 15,000, 1,500 to 15,000 live births. So it varies across countries and places. So, and it is responsible for 60% of the cardiogenic shock. And then this now stands at 3.3% per 100,000 for peripartum versus 0.9 for rheumatic heart disease. So the natural history is that the prognosis depends on the normalization of the left ventricular size and function within the 6 months of the delivery. So most of the time that the women, 50 to 70% of the women will not return to normal left ventricular function. So they will have a persistent left ventricular dysfunction. And in this group, it's actually quite serious that the mortality rate will be 85% over 5 years. So we are worried that, and you can see that it has a mortality of 18 to 15% in a year. And we are worried in South Africa, a maternal death, we'll say it's a maternal death up to 6 weeks. And now if this condition is lasting up to the end of the 5th month, then it means that we may be missing a number of patients. So people have been very keen in investigating. This has been Silva, who was a consultant in Grooterschuur, and with their group, they looked at a single study where they took the 100 patients with peripartum cardiomyopathy, and you can see that 15 of those 100 died, while 23% had normalized only, let me not say while, only 23% normalized their left ventricular dysfunction despite optimal medical therapy. So in our rural setting, the question is how do you even assess that left ventricular function? You haven't assessed it in the first place, and therefore you will know we don't even know what's optimal medical therapy. So you can see that this disease is significant. What worries, if you look at this natural history, so if you see the lines, you've got all groups, but I just want you to see the behavior. So in this current pregnancy, you can see that the white lines, right? These patients have got these two groups. They have a white line and they have got peripartum cardiomyopathy. Then if you follow these patients up in the postpartum, how is it? Hey, as you know, look at it. Postpartum, how high the graph goes, in the postpartum period, in all the groups. But what is said about us is, I don't know with you clinicians in the room, when a person has been diagnosed with peripartum cardiomyopathy, they need to be advised about their contraception for the subsequent pregnancy. And if you're looking at the next pregnancy, these patients are at risk. So the issue of discussing contraception with them is very important so that they don't fall pregnant again in the subsequent pregnancy. But this tends to be omitted. And then you can see that, at follow-up, they still have problems. So as we could see that only 23% of the patients, they don't have a return to normal function of their left ventricle. So what is the pathophysiology, right? So there are a number of factors, right? So they say it's genetic, right? So we say, okay, it can be running in the families. And then we said we have other possible. So when you see someone who's malnourished, autoimmune viruses or cardiac stress, they could contribute. And then we can have this angiogenic imbalance. So where there's excess prolactin, and also there's the excess placental SFLT, which we cannot even measure in our setting. And then this can also cause now other endothelial dysfunction and cause an oxidative stress. And then this will cause impairment of the survival and causes a cardiomyocyte apoptosis. So that's the problem. This is what they call the two-hit theory, which then causes this imbalance and it kills the heart cells. So when you have a patient who's presenting, so the presentation is typically, like I said, edema, shortness of breath, raised JVP, they feel tired. So it may be quite non-specific, but it's actually important that when you have, or it could be shortness of breath with a tachycardia, or this patient can have florid heart failure signs, raised JVP, bilateral basal cripples, and all that. So your first diagnosis must be like, this is dilated cardiomyopathy, of which you need to really consider doing a chest x-ray, and you need to do an ECG and echoes. But it could be valvular heart disease. You need to check if have they got hypertension. Remember, these patients could be also having preeclampsia, and then because they have preeclampsia, they've got complications of preeclampsia. Then valvular heart disease, congenital heart disease, hypertensive disorders. So those would be the ones. And then others, you remember that it could be this complicated Takotsubo cardiomyopathy, myocarditis. Then remember, with all the shortness of breath, you must always say that, is this patient having a heart attack, right? Is she having a pulmonary embolus, or is this related to the HIV? So there is a number, the HIV is affected. So you can look at this clinical, Dr. Ndosi is actually lead in terms of writing these articles and also investigating the cardiomyopathy. There's this comparative study that you can look at. The issue of the association with the HIV is not clear whether people with HIV should be defined under the same, but they thought that the pathogenesis is different and possibly needs to be healthy. And therefore, that's why we're saying, ideally look at your viral load, your CD4 counts, and encourage people to use contraception until they are fine. But it wasn't like particularly saying HIV positive people will have a higher mortality. Then I think I've talked to this as well, trying to explain this. Now, then, when you're looking at the medical management, okay, let's look at this now. So you can either be when the person is pregnant. Remember, I said these patients will present from 36 weeks to term, and then others will be postpartum. So in the management, right? So the first one could be, we have to think about once the heart is very big and the heart has become big, there's a tendency for you to have thrombi in the heart, and those thrombi can then migrate, and then the patient will have a emboli to the brain and will have a stroke and all that. So it's very important that once the condition has been identified, you have to look at the issue of anticoagulation. Number two, all right, beta blockers. So you know that we really use beta blockers in pregnancy, but we will consider them. And then the diuretics are very important, which is furosemide. We're not really using HCTZ in the pregnant patients, but increasing your furosemide and therefore will be important. Then now ACE inhibitors. So when people are still pregnant, it's not the mainstay of the treatment, but then the ACE inhibitors, you need to increase their use in the postpartum period. So as soon as those patients deliver, give them Lasix, and you quickly change them and you start them on, and this is on the ACE inhibitors to improve the preload of these patients. And then you then start adding beta blockers again, just to drop the heart rate, because if you use a beta blocker, you'll improve the heart rate, and therefore you can improve the circulation basically both to the baby, and therefore you can improve the outcomes. And then spironolactone can be used now post-pregnancy, not used when people are pregnant. And then let's come to the bromocriptine. So if we use bromocriptine, we use 2.5 milligrams a daily for 7 days or higher dose, or longer, right? So in patients that have, they are severe. And then we can use, we know that we use hydralazine, which is a nitrates. And when the patient is quite acute, you need to use sublingual glyceryl trinitrates, and then even if they are pregnant, but then you will use them more as vasodilators, and we don't have the other drug. So I think that, remember, why are we not using ACE inhibitors? We've got two problems with these patients. ACE inhibitors, they cause renal artery stenosis, and they can have an impact on the fetus. So that's why that we are not using the ACE inhibitors on these babies, on these mothers, is to protect against the renal artery stenosis, which can be a side effect for the babies, on the baby. So it's not just about the mother, it's also about the baby and the effects on the baby. Now, so in the long term, in South Africa, it's very tricky because you're gonna use bromocriptine, but the question is, what about the baby? Does this mother have money for food? Can they feed their baby? So really, the breastfeeding is discouraged in patients, and bromocriptine will block prolactin, and you can see the standards, like using bromocriptine with a hypertensive heart failure is actually useful in the acute setting. As to whether, and using it if the ejection fraction is less, will lower the mortality. And there has been randomized studies that compare short and long-term effects of bromocriptine, especially if the patients have got an ejection fraction of less than 33. Both low and high doses have improved the mortality, right? And it was not justifiable to a point that you can't use a placebo. And the longer term, the treatment they tends to be associated with a much better recovery. There was a Canadian study which reported improved recovery in left ventricular function in patients who were treated with bromocriptine. And therefore, the bromocriptine is recommended in patients with ejection fraction less than 25, or if they had an episode of cardiogenic shock. And they should be given together with prophylactic anticoagulation, right, such as Clexane. And there have been cases reported of cardiac complications with coronary thrombosis with bromocriptine. But generally, the studies are suggesting that it is good, and I'm not sure if we're using it. And then I just want to refer to this article because many patients will say, why are you saying it's cardiomyopathy? This could be the effects of preeclampsia. So it is actually clear from this graph, if you look at this graph, the red is the hypertension, right? So we said all these patients, with the peripartum cardiomyopathy, it will start at 36 weeks. But if you look at the patients with hypertensive disorders, you can see they will start like prepartum before delivery, 36 weeks. There will be far more. The majority of the patients with preeclampsia, it will be there for as long as the patient is pregnant, because the disease itself is actually being driven by the placenta, by the presence of the placenta, and the chemicals, that are coming from the placenta are driving the disease. And once the patient has delivered, the disease should actually get better. So if you look at the red, you really see that the highest peak is when they're pregnant. When they get to the first week postpartum, it gets better. And at 6 weeks, at the end of the first month, the preeclampsia should get better. But look at the behavior of the patients. But you must remember, if the patient at the 6-week postnatal visit still has some protein, still has some symptoms, still has disease, you must remember that preeclampsia, it's in fact, they'll get better and the symptoms will actually recover. But in the long term, it can then still start showing the complications, because you may find that the patient had severe renal dysfunction, and the complications were so much, on the kidneys. And therefore, after the 6 weeks, you may find some of the patients are still continuing to have disease, even though most of them will have a reversal of the disease. But if you look at the blue, right, look at the disease, yes, starts at 36 weeks, but where does it peak? In the first week postpartum. It continues, but look at it after the first month postpartum. That's when most patients now start to deteriorate. And that is why, colleagues, in the maternity case record at the back, there is a page that is saying danger signs postpartum and the presence of shortness of breath. I remember when I was pregnant, after I delivered, it was like, what a relief. I felt better. My heart rate was better. The tachycardia was better. I could handle myself a little bit better. But in these patients, and after that, you can sleep with one pillow, the sleeping is better. But the patients with peripartum cardiomyopathy will actually feel a little bit worse after they've delivered. And this is something we need to counsel our patients about, especially if they have the risk factors, which is what I said: multiparity, the age more than 40, high parity, high gravity, increased maternal age. These patients need to be specifically counseled in the postnatal ward about the risk, the pillow use, the shortness of breath afterwards, and be told where to present. Because when we've reviewed some of the charts, you find when the patient is 6 weeks or 8 months, they don't even tell that, oh, I was pregnant. And when a patient with shortness of breath presents at a casualty in a clinical station, what will they get? They will not be given heart failure treatment. What they will get is NEBS, Solucotef, theophylline, and they will be treated as asthmatics, especially if they didn't even disclose that they had been recently pregnant. So we need to deal with that. And this I find is the biggest gap in our care. Postnatal ward, the interns can do it, the nurses can discharge these patients without us seeing them, but nobody pays attention to these patients who have grand multiple. That's the opportunity for us to say, look, let's make sure there's contraception. Let's counsel on the symptoms and on the signs. But this care, I think, is a very serious missing gap in our care. So coming back, so I hope that you've understood. Other part that I wanted to tell you is that if a patient has an echo and the ejection fraction, let's say, is 20, they need to come back at the end of the 1 month for reassessment at 3 months and at 5 months. So this follow-up doesn't end at 6 weeks for patients with peripartum cardiomyopathy. And if the opportunity to give them long-term contraceptives or a TL or an IUCD was missed, it's the ideal opportunity, because in the next pregnancy, they will have the disease, and at the end, they will actually have the disease. We could see the recurrence, of this disease in these patients. So we can see that, so if we could see a comparison. So just in a nutshell, I'm going to summarize the findings from the report. You could see that we had 101 patients, 28 patients of the 160 plus patients had rheumatic heart disease and the others had another form of cardiac disease, be whatever. So we can see that the cardiomyopathy is the most common one. And we already talked about the fact that these patients attend ANC because the disease doesn't really present predominantly in the antenatal period. And you can see that 82% attended ANC. HIV, there's not really much of this is patients with cardiomyopathy. You can see that 61% of these patients were negative, so the association is not clear. Those who were positive on ART, and then the presence of anemia is another risk factor. So you can see that 19.8% also had anemia. So anemia must be, a reason for you to suspect the disease, and the mode of delivery was similar, be it NVT or these were delivered by Caesar, but I'm concerned that if these patients have a tachycardia, they deliver by Caesar. Remember, if the patient has a pericardial effusion, if you do a spinal on them, they will die, right? So it's actually very important that those who deliver by Caesar, that they are examined, and the people who are giving the anesthetic must look properly for anemia, for this, and they must themselves personally examine patients before they dope them for anesthetics. And so to look at our own patients again, so I talked about the timing of the emergence and the death. So the findings were very similar to the study that I showed you by Ndusi, which you can see that when did they present? You can see that 59 of these patients presented in the postpartum period, and then 75 of those who died also died in the postpartum. There was 2 that died in the anesthetic. So when you give anesthesia, and you can actually see that this is different from rheumatic heart disease, which more of them are in the antenatal period, but then also some of them are in the postpartum period. That is why that those patients need to receive Lasix post-delivery. This is just to reduce the preload, because there's a lot of blood that is circulating that was in the placenta. So once the placenta is out, that blood comes back into the intravascular space. And when it goes into the intravascular space, it can overload the heart. And when we really looked at the administrative problems, we really said, okay, the problem, if you talk about cardiomyopathy, so you can see ICU, other medical and surgical conditions where the issue was ICU and the skill on site on standby. But with cardiomyopathy, overburdened service. So the tertiary is just overburdened, the monitoring won't, and then you can actually see that lack of healthcare facilities. So like there's no facility to take this patient, or inadequate number of staff on duty. So you have this patient, you are in a district hospital, but the number of staff don't give us the enough people to monitor the patients to the frequency that they need. So we can actually see that when the deaths have been assessed, you'll see if they were potentially preventable, and we can see that 60% of the patients who die of rheumatic heart disease, right, of these conditions were actually quite preventable if the problem had been recognized and were given the right treatment. Then then you would not have had the problem. And then what are the recommendations, colleagues? So the recommendations is really now to strengthen SRH. Sorry, this one is wrong, is in the wrong place. We've already talked to these factors. The factors here specifically to cardiomyopathy is that really the deaths from peripartum cardiomyopathy are definitely increasing. Anemia is mismanaged, and we're not dealing with it and correcting it, until there's the time for delivery, and then things actually get worse. And these patients, they were anemic, but they were booked. So what is the point of giving this iron? And then if it's not improving, we have to look at alternatives like IV iron. And I think that somebody had presented on anemia in pregnancy before me. You can see that the postpartum period is very important, and therefore you need to say, if anyone delivers twins, colleagues, you must tell them you are going to have likely to have peripartum cardiomyopathy. And I've said focus on those risk factors. And remember to provide the contraception, as postpartum cardiomyopathy is recurrent in the next pregnancy. And I know that you guys love podcasts and the fast, and then these handheld ultrasound, where there's like a good opportunity to train doctors on using this handheld echo. So what we did as ONG, we really lost Prof. Parrish, who was doing most of our echoes at CMH, and there's no echo service at Frey. So I don't know about your other districts and hospitals, but we have had a training on the handheld echo. Yes, we are ONG specialists. We used to handle probes, but it wasn't as easy as we hoped. But I think that it's a learning curve that we are prepared to explore. And we have trained all our ONGs now from, with a sample, I think we trained about 30 people, like some from the districts that already have got machines which have got the cardiac probe. So I think it's just to recognize that the cardiac probe is very small. It must be able to fit an image between the ribs. So therefore, you can't use any linear probe or whatever, because you won't get it into the space to see and measure what you want. So therefore, I think just to look in your hospitals, do you have that small tiny probe? And if you do have, then maybe there's room to teach yourselves or learn how to just do a screening echo on our patients. The implementation of bromocriptine, I'm not seeing people use it as effectively as it should be. And I think that these transitional high care beds, they need to be created at the district hospital to prevent the delay in initiating. So we should be getting, some hospitals should be getting ventilators that they can ventilate patients, and something called bypass criteria. So we have an SOP here in the Eastern Cape, which is for bypass, which shows which patients, even if they present at a clinic, must be sent straight to a tertiary. So to avoid delays in then first sending them to the district hospital and then sending them on. And these cardiac patients and patients with cardiomyopathy are some of the patients that are communicated in that bypass criteria for people to be sent. So acknowledgements, there says the people that are involved, provincial assessors and CMT members, there's some references there. And I want to thank you for listening, and I am happy to take questions.
Okay, just before we take questions, I am going to post a poll. The poll is what you need to fill in if you want CPD points. So you should see the poll on your screen now, and you should be able to fill it in. If you can't see the poll, it usually means that you're on a phone and you're not on the Zoom app. If you just put in the chat that you couldn't see the poll, I will send you a Google form link. Okay, and then while people are filling in the poll, you're welcome to ask questions. If you just raise your hand, then we'll be able to see you, or you can post in the chat.
I'm not watching the chat.
Yes,
I'm
watching the chat. There's nothing in the chat at the moment.
Okay.
Can I ask you, is it possible for you to email that Eastern Cape bypass criteria? Some people might be interested in that.
All right.
If you email it to me, then I'll send it out.
Okay.
That would be great.
That's perfect. I'll email it, and we'll also try and post it in the different groups. It actually helps. Initially, many patients were struggling because the ambulance crew would insist on dropping them to the closest district hospitals. And I think as soon as we could get that right, yeah, there was an improvement.
Okay, at the moment, I don't see any hands or any questions.
Oh, okay, that's good. Good for me. All right, thank you, colleague. How many patients have had, can I just get a feel of hands? With people's in their experience with getting echoes for their patients. Are people seeing the gap? Are they struggling with echoes? Can we just get one? I don't know how many people are even in this meeting.
There's 58 people in the meeting.
Okay, Can just someone say, like, what is their experience with access to echo? And then I'd just like to hear if there's anyone here who's attended an echo training and that they found useful, and if they're using those skills. It would help us a lot to know, just in terms of planning for the future. You can just unmute and talk. Hey,
Yes, I'm not quite sure what's happening. Usually there's lots of questions. And
I'm also feeling bad now.
yeah, there is a comment in the chat saying thank you for the presentation. It was very helpful. And I also posted the link for the BeWise app in the chat. Okay.
Okay.
Sorry,
Tendo?
sorry. Good evening, colleagues, managers. Can I basically, okay, first of all, I'm Thando Ngwenya from Sibande district at Mpumalanga. I was going through, first of all, I would say, no, Dr. Mandondo, thanks for the presentation. And yes, it was fruitful. And I was going through the participants here. I haven't spotted maybe one or two of our doctors that have joined. And really, this was a teachable moment. And I'm a MCWIH program manager at Sibande. So in terms of the gaps or problems that we experience at heart, I'm one of the cadre that will do the PIP meetings, collecting data, analyzing with the other doctors, and otherwise I don't have a DCS team. I'm just doing things on my own with other assistants from program managers. But the DCS, I think, is in pipeline to be employed or hired. So my request from Dr. Mandondo is that can you perhaps share the presentation? I will put my my email address so that you can share with me the presentation that you presented, so that I can maybe forward it to Dr. Makinde, because our representative on our side is Dr. Makinde.
Okay, so Tendo, what happens is that these are recorded and we put them up on YouTube, onto the Radasa YouTube account. And all of our webinars are on there. So I usually take a couple of days to get them up, depending on what the connectivity is like.
Okay, so that it is not possible to have the presentation.
But the presentation, that is the presentation.
Or where can you get it?
Okay, so I am I'm just going to give you the link in the chat.
Maybe, yes, I was going to suggest that you share the link. I know Dr. Makinde. I can, okay, we also have things called Funda Fridays here in the Eastern Cape. So I'll also let you know, maybe my number is 060 560 2474. And we can share. Then I think it helps for people to listen to the presentation that I made. So then the other thing is that this information, if you go to the Saving Mothers report, to the National Department of Health website, the Saving Mothers report, you can then click there and then you see the version 2. There is a lot of information that you actually can get. So everything that I've presented, remember I wrote the chapter and this information is available nationally. And therefore you can actually go and look at this report, and actually see what it says. It will show all these indicators. The reason I'm not going to share the presentation is because...
Yes, continue, Doc. Continue.
No, I think that I've submitted it for publication to a journal. So, you know, the journal wants people to be interested in the article. So if you can look at the latest journal, you can actually get the journal. It published all the issues around maternal deaths. It's called the African Journal of ONG, and I'll send it to, I will send it to the group as well, and to the Rudasa team to actually circulate. And I also just wanted to say that I think for me, I don't mind sharing my presentations, but this particular one, its content is actually there in the Saving Mothers report, but the other content is actually still awaiting publication. You know,
Okay.
and because of that, I can't
Yeah.
share it before it's published, you know, but the
Yeah.
recording and everything for the presentation. But I can share like a basic presentation on peripartum cardiomyopathy or something like that, you know.
Yeah. The problem is that the way you presented it is like you were presenting a Harsibande, most maternal deaths. So that's why I was like, yeah, no. But anyway, yeah, I got what you said. I will try, and we will also. I'll also put Dr. McKinney on board, maybe to contact you for maybe to do follow up in terms of the journal is being finalized and so forth.
It's it's fine. I'm gonna meet him in the meeting next week. So I'm also there in the meeting. We're gonna be together there. I'll have a chat
Yes.
with him next week on the 14th, on Thursday we have a meeting, so we'll discuss it. But please look at this African journal. Colleagues, please look at the African Journal of Obs and Gynecology.
It's AFCOG. I know, if I'm not
Yes.
mistaken.
No,
Yeah, I
what
know
I'm
this one.
saying is what has happened in the journal in March, the publication, we wrote about all the critical things. Like we found that with Caesar, there was problems with cesarean section and there was bowel injury. So the issue of lack of recognition of bowel injury and cesarean section is a serious issue that we are facing. So there are different things that you can you can actually deal with, you know. So the other question is talking about, can I repeat what I said about the spinal anemia? I was saying most doctors will go to theater and dope patients without looking at the history. So if you are the surgeon, you must look, and if you are the anesthetist, you must actually also go and look, what was the HB of this patient? If a patient ever had an HB of 6 in their pregnancy, it is likely that as the pregnancy advances, these patients have a cardiomyopathy. And therefore, it's very easy when you lie the patient flat and you're trying to dope them. You may, and I also had a recent maternal death where the patient had had an HB of 6 for about 3 months. And then as we tried to improve it, somebody thinks, oh, let me just transfuse them. And when they are transfusing, they're overzealous, put a bit food, preloaded her with fluids. And by the time they finished transfusing the first unit of blood, the patient arrested and died. Because these patients do not have the reserve and their heart cannot cope with the fluid volume. So these are the things that are going wrong. So that's why I'm saying if you dope somebody, if they are anemic, we've got IV iron, Venofer, try to use from 36 weeks. If someone is still anemic, they need to go to hospital and we need to decide, are we transfusing, and of which the transfusion will be 1 unit over 8 hours, lay 6 in between. You keep on checking, you have an x-ray, you know how big is the heart and everything before you proceed with that. You know, so these are the things that go wrong with these patients. So that's why I'm saying that the patient, if the patient has a pericardial effusion, remember now the capacity of the heart to even get bigger is even less. If you give a spinal with a patient, you didn't see that the tachycardia was related to a pericardial effusion, the patients arrest and die. So these are some of the cases that I said, 2 cases that died intra-operation at anesthetic. So these are risk factors for you doing the anesthetic, you know. So everyone must pay attention.
Noted. Thank you, Doc.
There's a hand.
Yes, there is
from
a hand.
Natasha.
Hi, good evening. My name is Dr. Papavanavas. I'm a community service doctor in the Mopani district of Limpopo. Firstly, thank you for such a lovely, informative presentation. I just wanted to give some feedback personally, what I've had from the echo you were asking about. I think just in general, yet alone for pregnant and maternal patients, especially the more junior colleagues, which is what most district hospitals are composed of. It's a lot of your ComServes and younger junior doctors. I don't know how to do an echo properly. I mean, I've done the ultrasound POCUS course or whatever, but you know, I think it could be really beneficial, especially, you know, when you're so rural and far away in these district hospitals. If you could just, like, even if it's a short online course or a one-day course or something, just to know the basics of how to do that echo, it can save a lot of time, because the delays in getting an echo, you can't get through. There's 80 to 100 patients waiting at the clinic to be seen, and you can't spend forever on the phone trying to get an echo. I think, you know, if you can learn the basics of that echo, even just the basic ComServed or junior doctor, I think it can really save a lot of time in referral pathways and just improving, you know, catching and preventative care starting at early on. I personally would love to learn how to do it. I'm trying to teach myself on normal patients so far, because I'm in casualty at the moment. But I do know a lot of my colleagues, we would love to learn more, but we all struggle, you know, because again, necessarily there might not be a consultant at the district level hospital, or you just trying YouTube videos or whatever. So I think in the future, maybe as a long-term goal, if it could maybe be an Echo Pro, like just bare basics, you know, what the basic doctor can do to identify things. Listen, we need to flag this patient. We're worried. These are the risk factors we're aware of for the cardiomyopathies. I think it could really help, because obviously if they tip over into CCF, you know, is it an HPEF or the preserved ejection fraction? Those are different treatment managements as well. So I think it could be really beneficial, because a lot of our, from what I've personally experienced in my limited experience as a community service doctor so far, a lot of us are very junior, eager to learn, but unfortunately we don't have that expertise that might be available at a tertiary institution. But again,
Okay. All right. Thank you, guys. I fully sympathize with you. We are also frustrated with a lot of our hospitals run with ComServes, and all the ones who are experienced, they leave a year later, then you get new ComServes. So I'm also happy with Mr. Ngwenya from what is this district? So what we did here, there is this company called GE. GE is an ultrasound company. So because we were buying equipment from them, they then were able to come to our province and said, if you can have 15 people in your district, and then we want 5 people, they came with 3 facilitators. If you do have any of their machines that have got that probe, they can do the training for you for minimal cost. And then they normally come and they do a 1-day course. They've also, like when they came here to South Africa, they came to do, so you can see this one, Heart Part 1, Heart Part 2. Please look at those 2 links. That's where you can start your basics before they come and train you. So please ask your managers, like your provincial manager or your manager, if they do have these GE machines that have got this cardiac probe. They are often available in casualties now. And if you can get those machines, I would be happy, and they will be happy to come to, they don't want to come to the whole province, but if you guys can come to the place where they are in the hospital with the machines, you can learn the skill. I'm still waiting for them to give us the EchoMate Easy. You can take my number and then WhatsApp me and say, please remember to copy us on the manual. They said they were going to send us a manual of EchoMate Easy. We did the training with them now in July, so I'm sure that we can share these, and then whoever is the representative will organize the training for each province. Oh yeah, you can take that up with them.
Sorry, thank you so much for that. Just one more question. You mentioned Funda Fridays. If you're not necessarily working in the Eastern Cape, are you allowed to join those meetings just to further increase your knowledge and professional development, or is it strictly for Eastern Cape healthcare workers?
No, it's open, just like Rudasa, it's open to everybody, but it's just a question of like me getting your details or putting you on this group called Funda Friday, so you can get the link. The links are not always coming as and we don't advertise as broadly, but every first year, so it's every, what do you call it? It's from 8 to 9 every Friday. So we do different topics. The first week we do maternal, the second week we do peds, the third week we do other family medicine related, and the fourth week we do HIV. Actually, the same person who's organizing Rudasa, and then some are recorded. So you are more than welcome to attend our sessions from 8 to 9 every Friday.
Yeah, so the Funder Friday adverts usually go out on the Radasa buddy system. So if you're a Radasa member, you should be seeing those ads.
Thank you so much. Thank you.
Okay.
So I don't see any more
So
hands.
I think we
There was just somebody asked, could you repeat what you said about spinal and anemia?
I clarified it.
Okay.
That's what I was saying, that the patient has got a peripartum cardiomyopathy, what's this now?
Okay.
Pericardial effusion. A spinal is dangerous for them. So I think it's important that if you have any concern, with a tachycardia, you must check that heart. If the heart is displaced, try and do an X-ray and avoid spinal anesthesia in patients with that with the pericardial effusions. This could be related to TB, so patients may have other TB symptoms or signs.
Okay. Thank you very much for spending time with us yet again, Dr. Mandondo, and thanks for everybody that attended. Okay, if you are looking for CPD points, then we have to get them to Health Professionals Council within 2 weeks. I have to tell you that I personally have still been getting points from something that I did in February and March. I got them this week. So there is a bit of a backlog actually at Health Professions Council. For our next RAMP webinar, it's
Sorry,
due
Steph,
on...
I can answer the question. You don't need, people are asking, do they need consent if patients must go for x-rays? If there's x-ray is indicated, remember the teratogenicity and all those things are less than 10 weeks when the organs are forming. The rest of the time, there's no teratogenic or kind of effects with the gaze that you actually get from a chest x-ray. So if the x-ray is indicated, there were no ultrasounds before. People, if you wanted to diagnose twins, would x-ray them to confirm they had twins. So there's nothing that's going to happen to the babies. It's just a verbal consent. And if you're getting resistance from the nurses or from the people at radiology, you must look at the guidelines and say, it does say we must do the x-rays and it's mandatory and it's a primary investigation. So please feel you don't need any special consent. Patients must go for x-rays if there's a need. You lose more people from not x-raying than any congenital effects of the x-ray on the patients. Thanks.
And then just to let people know that our next RAMP webinar is on the 3rd of September. It's on a practical approach to palliative care, but this is palliative care within the emergency setting. So it's not sort of long-term palliative care. Okay, thank you and good night, everybody.
Good night. Thanks for organizing, Stan. Well done. Keep it up. The good work.
Bye-bye.
Thank you. Bye.
Eastern people are and for man.
Thank you.
And this